So I think we're going to go ahead and get started for the discussion section.
So it's come back, and that was the point. It's all come back, and it was wonderful.
So thank you for hanging in there this afternoon and contributing to the discussion. And we have 3 people who are willing to represent you, so that's great. Mona and Heather and Theo, right? Okay. So the Solberg paper was on APT training and education. And why don't we just start with the theory? Mona, would you like to go first, telling us what your group thought about the theory?
Well, this one seemed to be working on restoration rather than just compensation. So restoration of attention and working memory.
Okay, restoration of attention, all right, so that's one aspect of the theory. Yeah, Heather?
We talked about the theory that attention is supported by networks and is hierarchical.
Okay. Attention is supported by networks. And what was the last part that you said?
It's hierarchical.
Okay. Is anyone going to comment on my spelling? I hope not.
That's good.
Okay. So it's, all right, and anything else?
There's a theory behind process training that attention, kind of the metaphor of attention as a muscle, which is similar to,
okay.
Again, that attention can be separated out from other activities. Patients with higher vigilance will respond to more complex attention tasks.
Okay. I don't have a spell check here, if that's the problem. And the last one was it can be separated out from other processes, and then what was the last one?
The vigilance thing.
Vigilance, right. So
Patients with higher vigilance will have basically the vigilance.
Higher vigilance
Or interaction.
will do better on attention training. Okay. All right. Theo, how about your group?
My group had people who ranged in their knowledge of APT, so while we thought that the theory was not well explicated in the article, that the manual actually does a very good job describing it, so we consider this a neuroplasticity-based treatment that affects the neural networks, and it's based on the theoretical attention hierarchy, which is already up there.
Okay, so we got that.
Oh, go ahead.
There was a statement about a speech-language pathologist being required to deliver the treatment, but we couldn't see a theoretical rationale for that.
Okay, so that was just kind of a statement, but that wasn't a theory, really.
Well, if there is a theory about that, it wasn't there.
There is a theory about speech
If there
delivering.
is one, that wasn't in the.
Ooh, I'd like to hear that afterwards. Okay. All right. Okay. So it looks like there was quite an attempt. Oh, yes, Mona.
I'm not sure I understand what the attention is a muscle. That's the only bullet I don't. If you could just.
That repetition will improve, much like.
Oh, okay. Okay.
Repetition.
So the question was, right, so the question Mona asked, what was the interpretation of attention being a muscle? And Heather, you said, I'm going to speak into the mic again.
That repetition will improve performance on the outcome.
I think we're having trouble. Yeah.
Sorry. Just the basic idea that repetition helps, I guess, to state it simply.
Okay, so John, you have a comment about that?
I just wanted to make a point about, I think, is it Heather, is that your? I would say that some of the theory stuff that you said is a theory about attention as opposed to a theory about treatment, which is, it's a complicated thing, but especially in the area of neuropsychology, I think we've had the problem that people think that if you lay out how language works, you know how to fix it, or how attention works, you know how to fix it. And I actually think that the theories about how to change something are often quite distinct from the theories about how they work when they're intact. So the part about repetition with challenge and hierarchical blah, 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 I think that's where the real essence of the treatment theory is.
Mm-hmm. Any other comments? Ira?
I guess I'll say this out loud. I've been thinking this. I think sometimes we confuse theory with a hypothesis. Mm-hmm. And, you know, studies have an hypothesis that you're trying to test and the null hypothesis, mm-hmm. and you usually do that. Theories are kind of like a big overarching paradigm that you look at. So I think sometimes when we're talking about what's the theory, we're actually talking about what was the person's hypothesis, because I get a little bit confused when I hear this.
Right. Okay. Thank you for that clarification. So anything else about theory? So really we can say that there is some theory behind the study that that some of these theoretical ideas are actually in the manual, are spelled out in the manual better than they were actually spelled out in the article itself. But the manual is available, so people can go and read that. So I think that's good. Any other comments? All right. The second part is to think about broad goals for the next phase of research. Should it be proof of principle, treatment, optimization, efficacy, effectiveness, or cost effectiveness? And I don't know if we want to do that one next. How about if we skip that and come back to that? Maybe we kind of come back at the end to that. Let's talk about, could we talk about number 3 for our panel, which is the appropriate patient care. What are the appropriate patient characteristics? Heather, would you like to start?
My group talked about, obviously this was a very small study.
Oh, thank you.
And the patients included were very heterogeneous. There were anoxic patients, for instance. And so we would want to, moving this along, have a more homogeneous group. And with regard to the diagnosis and also the severity level, which was quite broad.
Whoops. Narrow severity level. And the third one, you said homogeneity and narrowing the severity level. And the third? No, that was it? Just 2? Okay, Theo. Diagnosis. Oh, similar, same. Right.
How did you remember that? Good memory.
Okay. Theo?
Yeah, so we also thought the population should be more homogeneous, and in addition to the diagnosis and severity, we also thought that length of injury, so time since injury, and perhaps age, because that might have an effect on vigilance, for instance. We also thought that it might be interesting in the inclusion to look at imaging studies to see the integrity of the neural networks that are hypothesized to be implicated in attention, to see if those are intact, and include perhaps people that have lesions in those areas.
Because that was related to their theory?
Correct.
Okay.
we would also broaden the recruitment efforts to avoid selection bias, given that these were referrals from clinicians who knew about the study, so there might be kind of like a double
Oh, so there
layer
would be
of
some
stuff.
bias, yeah, okay. So reduce referral bias. All right. Is that it? Mona?
I've got nothing to add, except that we didn't feel you necessarily had to exclude people because of memory impairments. That-
Okay.
that-
Did you have a discussion about that, or?
It didn't seem to be that critical that they have retention. They did need working memory, but this
Right.
was supposed to train for that. So that was the only point. Otherwise, we could
Okay.
agree that more homogeneous based on lesion and severity would be
Okay.
helpful.
Well, I think the discussion in our group around the severity of the memory impairment was the fact that they lost 2 in the interview because they didn't remember having therapy. So I think that was because 2 dropped out of their data set. So, not at all. Okay, should I hold it? Is that going to be better? Yeah? What? All right. Sorry about that. Okay. Anything else? Any other comments about patient characteristics, what they could look like, or, okay, to move the field ahead? All right, let's go to number 4. To what should the treatment be compared? The comparator. It was a crossover design with broad patient education. So, Theo, what did your group have to say about the comparison?
Well, we didn't necessarily think that the approach that they described was devoid of any component that might impact attention because of the relaxation, visual imagery, and these exercises that were included. So some alternatives would be an educational approach that doesn't have these components. It would be a no treatment, so a non-active or a waitlist control design. Also, we considered treatment as usual. We kind of went from using the term standard care to treatment as usual because
Okay.
we don't really know what the standard of care is in terms of attention. I think that's it.
Treatment as usual, not necessarily knowing exactly what that is. But
But we know treatment as usual would be whatever somebody gets in the community, for instance.
right,
But we don't know what standard care is, so we wouldn't include that.
right, and there would be a lot of variability around that.
Right.
So that would be the problem with, yeah. Okay, Heather.
We also talked about the education comparison and how it didn't seem to be completely inert. There was an effect,
Right.
a small effect, it seemed like. So our group talked about that a little bit and about what is it about that group that was kind of similar to what you said, that was maybe important to learn about in and of itself. We also talked about computer games as a potential similar type of task that's activating. There was discussion about the questionable baseline, which you would need to control for, having them ceiling on it and then start from there.
Would
Am I
that be?
am I forgetting anything?
Would that be in the comparator or the was that something about the experimental design?
Well, I had it
don't-
under number 4, but that's probably design.
Okay, well, I'll put it there. It could be a part of design, just having that extended baseline. And then because they didn't have that baseline, so there could have been practice effects. Baseline. Okay. So Mona, how did your group?
Same
do?
thing, not much to add. At a minimum, we felt the comparison group should be a no treatment group.
Should be
A
excuse me.
no treatment group.
A no
But you
treatment
could
group.
have additional groups, but at a minimum, you should have that group.
Right, okay. Any comments about that? I think the rationale for the education group was that education training is a part of standard of care. So, so probably the rationale for including it was that, rather than having no treatment, that would not be standard of care. So I think they were thinking that they would get a bigger bump, a bigger effect with the APT training than beyond just the education.
Some of these patients were quite a few years post-onset. So, yeah, then you start to wonder, yeah, somebody who's had a TBI for 10 years, yeah, is there a standard of care? No, most of them don't get any treatment anymore. And, yeah, even if they do they at that point in time, yeah, still would get treatment for a basic muscle, or, yeah, if they would get treatment, it would be more how to manage life, yeah, with a big L. So I wonder, yeah, why, they had education. I certainly don't see it as a comparison or a stand-in for, standard treatment or treatment as usual. And I think it just, complicated this study.
Yeah, Ira.
So we had a little discussion on this in our group. There's a difference between treatment as usual and standard of care. And treatment of usual kind of turns out to be the default, what happens, because of insurance payments and, whatever it is. That's treatment as usual. Standard of care is usually arrived at by a consensus of people who look at evidence and saying this is the minimal that we should be doing. And it may vary geographically, or it may vary on this or that. But the reason why I think that's important is, and I know you've been involved in this, Mary, maybe you could inform us, if there really is a agreed upon standard of care, then that is the obvious control group for, all these types of studies, everything else being equal and, customizing it. So I just wanted to make that point. And is there a standard of care?
Well, there are some guidelines that are out there now that have been published much, in 2010, 2011. And so this study was very old. This was a 2000 study. It was very small. So I think it would be fair to say that at least in acute rehabilitation and maybe like just post-acute, that at that time standard of care or probably using the usual care was to provide education to the patient along with some kind of attention process training as long as they had attention deficits. So some of the uniqueness in terms of the results of this study had to do with that it added to the knowledge base that individuals with low vigilance or sustained attention don't respond as well to the more complex tasks that are in APT. So it was after this study that the standard of care or the usual practice began to change and become a little more narrow as we began to understand that not everybody responds to APT training, that it has to be individualized, and it needs to be people with higher levels of vigilance. So does that answer your question? Yeah, John.
Well, I wanted to make a strategic point, which is that we here, and I'm one of we here, have in a number of cases advocated a no treatment group comparison or whatever. I think those of us who write grants know that we would worry about saying that same thing in a grant application because there are so many reviewers who just, you got to have a control group. I mean, it's like a religion. And even though I think we could all articulate for this question, you need this kind of control, it is scary to try to articulate that to reviewers who we know we're trying to change their minds from a kind of reflexive default. So I just want to I just want to put that out there so we don't advise you all to not get grant funding because you're doing something that makes scientific sense, but reviewers will not understand. So.
Well, yeah, that's no different than what we've been going through, John. Yeah, Theo.
And from a practical point of view, including a standard treatment as usual, as a comparator, makes recruitment 5 times as hard. Because if the standard of care treatment has a good size effect anyway, and you're trying to demonstrate that the new treatment augments the effects, then you will need a huge sample size, which in my experience has been very, very difficult to obtain.
Right.
So that means that waitlist control trials may be
right, so you need a
better
really large,
alternative.
right, yeah. Okay. All right, so what about outcomes? What outcomes should be measured? Mona, what did your group come up with?
So the group felt that a neuropsych outcome was appropriate as like a primary outcome for the next study.
Was or was not?
Was.
Okay.
So that a neuropsych outcome was appropriate, but they also felt there should be some secondary measures. And they also felt there might be some value of including sort of mechanistic measures. So, surrogate markers, things that would show was there an effect on the brain.
So some tertiary level measures or just additional measures?
I don't know what you would call them, but I use the term surrogate markers.
Okay.
But whatever works.
Surrogate markers. So that gets back to what Theo's group said about imaging. Okay. Imaging, okay. Heather?
My group thought that there were an awful lot of outcome variables and they might want to reduce the number. There are a lot of comparisons made. We talked about neuropsychological measures that tap into various attentional networks. We talked about the interviews, and people liked that there was a quantitative and qualitative aspect. They could have done more with that, perhaps. They didn't report much data in that regard.
So they could have mined that data a little bit better, or assuming that they did it, reported some of those results. So, okay, so included more. All right, Theo.
Let's see, not much to add. We talked about a range of measures from imaging to the neuropsych data, and adding more real-world functional measures, and like the previous group to put more weight on the qualitative data as well, and perhaps doing qualitative analysis on what they had obtained, and also to consider the subjective perspective, so the person's perspective on what tasks are relevant to them, and measure their performance on those tasks.
So consider the individual perspective and think about functional tasks that would be important for them that would involve attention.
Right.
Is that what you mean?
Right.
Okay. Okay. So it seems like we've got a little bit of overlap and agreement here. So the neuropsychological tests were appropriate and include some as secondary measures and perhaps some surrogate markers like neuroimaging. There were too many, and based on this, they could then kind of solidify and hone down the neuropsych measures that they wanted to use, and then also really mine this data a little bit better and report it perhaps more, the interview, the qualitative piece. And I just commented to our group that this was the first qualitative study that I had actually seen in CRT. So, so that was just kind of nice to see that. And I think we've gotten better at that, and we've seen more of them now. Real-world functional measures and that consider the individual's perspective on functional tasks. So, yeah, Mona.
So we did also discuss a lot, like where the focus should be. That was it asking too much to expect training for attention to then translate into a real life functional measure, or was it that this would be a component to maybe other things that would also impact those real life functional? And so that
Okay.
was kind of a big
Okay.
discussion point. I just wanted to make sure that got somehow folded in, that we valued of course, the efficacy on real life function, but the question as to whether this study, an outcome that addressed the impairment, was really the appropriate thing, and that
Right.
that became a platform to build on something else. And so there was just some
Right.
tension that we didn't answer it. But
Right. And I think that's a really good point. Yeah, Theo?
You know, it's interesting because this theory and this treatment is actually focused on generalizability of the results. So it's almost embedded in the treatment, and there's a questionnaire that participants or patients initially get to see what areas of attention they have they experience deficits in their real life, and contextualization is supposed to be part of the treatment, and at the end you assess how well has attention improved in those areas. So you know, it's interesting that in this article they actually don't
Right.
emphasize that.
Right, right. Yeah, Ira?
So, again, this is from a clinical trials point of view, and it may not be relevant to CRT and TBI, but this is, you know, if you look at what's been reported here, this clinical trial, it's a pilot study, it's randomized, it's a crossover study, and that's what's really randomized in the study, and it is what it is. But I think as a pilot study, it should be stated that we're looking to explore the feasibility and a variety of outcomes. In a pilot study, that's when you want to look at all these outcomes, and you want to look, it'd be nicer if it was larger than 14 sample size, but you know, that is what it is. So I just want to point out that this should not, at least I don't view this as any kind of definitive clinical trial, and it'd be nice to be able to present it saying, you know, we're exploring this, we're looking at the practicalities, and if we wanted to do a clinical trial following this, this is what we've learned from this, and I think that would be helpful.
Yeah, we actually did have quite a bit of discussion on that point, but on the prior paper. So kind of like, you know, do you have a lot of outcomes in the beginning and then you hone them down, or are you much more specific and selective from, you know, out of the gate, and then you broaden? So it kind of reminds me of that discussion that we had earlier.
But I think the prior paper was much more definitive and robust in terms of analysis.
Okay. Yeah, John.
Well, I guess I also think we need to be a little bit careful about just saying real-world function. I mean, real-world function is a lot of things. And so the examples that Theo gave were sort of, what domains of life have you noticed your attention interferes with, and did those domains of life get better? That's relatively proximal. I would still say it's enablement, because attention isn't probably the only thing that affects those areas. But contrast with that with, do they return to work? Is that a good idea? So I really view these as sort of a sequential building process, and the farther away you are from a one-to-one correspondence, the more you need to either look for patients who only have one problem, or packages of treatments that address the multiple problems of which attention is one for this patient.
Yeah, so thank you, John. As you were saying, as you were talking, I wrote just how or where does attention interfere in your life? So that's kind of, that hones that in a little bit better. Yeah. All right. Any other comments about the outcomes? All right. Let's talk about the experimental design. We've already started to talk about it a little bit in the area of the comparator, what it should be. So Theo, why don't we start with you?
Got me off guard there. So we listed wait list control designs. We also stated
So you recommended waitlisted control?
one of the suggestions. Obviously, as we listed before, RCTs with another sham treatment or treatment as usual. We suggested a what was it? A delayed start design with two groups randomized, one to start immediately, another to start after
Deferred or
certain period
delayed.
of time, and then different end times for the two groups. Obviously, including durability and dosage in the design.
And what was the first thing you said?
Durability,
Durability.
endurance, of the treatment and dosage.
Okay. We had some discussion. Oh, sorry. I'll let you go, Heather.
Because I don't have much written here. I don't know that we talked a whole lot about design. We did talk about things we thought should be looked at, like self-efficacy, for example, order effects. You can help
Right.
me fill in the blanks. I don't really.
Right. We were concerned about order effects, but that only occurred just because of the way the results rolled out. So the nice thing about a crossover design is that if you really anticipate those treatment effects are going to be robust, then that's certainly the way to go because it shows you have experimental control. But it didn't turn out that way as robustly as they anticipated, I would guess, because of the education effects. So the order effects were problematic. And Mona?
So we had pretty much the same thinking, we thought this would be appropriate to follow it up with some sort of RCT, not, it could be like a proof of concept, it wouldn't have to be a big one, versus, say, an observational study. And we also agreed that you could probably build something into the design where you could start to get a sense of dose or the number of sessions required by doing additional assessments as you went. And we felt that, you needed at least 2 groups, but you could potentially do additional groups. And that you'd want, like I said, multiple assessments, so sort of an immediate, and then some post-intervention assessments, and then potentially a longer-term follow-up.
So with additional groups, though, you would need a lot bigger N and probably with more selectivity and...
We're just saying you could. It kind of gets
Right.
to this thing about whether you want to have the standard treatment versus the no treatment. It just...
what those arms would be.
Yeah.
Yeah. Ira.
One more clinical trial piece. It just strikes me from reading the literature, again, outside the field, there's a lot of data that are not being collected that could easily be collected that's time dependent. So give you 2 types of outcomes. One is returning to work. That's an important one. And there's a lot of gradations to that. Are you returning to work as volunteer, part-time, gainful employment? So you could put a lot of descriptors. But the important thing is what's the date that actually happened? Because if you have a large enough sample size, then you can use a survival analysis, which is much more powerful than the dichotomized analysis, did you return to work or not, during this period of time. And I learned also that the Traumatic Brain Injury Model System National Database, that has 15,000 people on it that have been followed for this period of time, could actually provide those types of data. I haven't looked at it yet, but could provide at least those types of assessment, and one can actually model a study in a sample size after that. The outcome could be tying your shoelaces by yourself too, it doesn't matter, but I've not seen this in these types of studies, and I think there either are observational data that could inform, or they're data that are not being collected that could be very informative.
Does anyone from one of the model systems want to speak to that or respond to that? A? No? A? I'm from Minnesota. A? Okay. Can we use? Can we have you use the mic?
Well, what Iris just said is it was informed by a very brief conversation that we had. So, and we spoke very briefly about this in our breakout session. So NIDR does fund for the last 23 years the national data, the TBI Model Systems National Database. It's the largest prospective database for TBI in the world, and collects data on folks admitted for inpatient rehabilitation, primarily moderate and severe TBI. There are a small number of cases for complicated milds. And the data points are inpatient rehab admission, 1 year, 2 year, 5 year, and every 5 years thereafter to death. So the benchmarks for maintaining contact with these folks, for being able to collect at this long a time point out are very, very good compared to other longitudinal databases. There's been a lot of work done on how to, by our data center and our grantees, on how to keep folks engaged so that we maintain high rates of return. The database, NIDR had funded a study about 2 years ago that enabled us to show the representativeness of the database to the national population. And so based on the results of that study, we've now attracted CDC's interest and have engaged in interagency agreements with them to use the database to answer questions that will allow for national estimates and on outcomes. So it's a very, very rich database. Ira was interested in knowing if it's available to the public, and it is. It's data collected with federal dollars, and we've made an effort in the past 4 or 5 years to make this known to researchers outside of the model systems. So we've developed a standard operating procedure that allows for access to those data. It's a simple 2-page form that's completed and submitted. De-identified data is then provided to these outside researchers that have an interest in it, often together with the opportunity, but not requirement, that the opportunity to collaborate with those who have contributed data, that is, data to the database, that is, the TBI model system centers themselves. So anyway, it is available now, and it's always been, but now it's easier to access it. And these more sophisticated approaches to analysis of the database are being implemented now that we have more dollars to do that. We have these CDC funds, so there's greater attention given to using these data. And it's an interesting proposal. Yeah. Thanks for that reminder. So the VA had a strong interest, and Dave was instrumental in helping to establish this relationship in essentially setting up a parallel database that would take those admitted to 4 of the 5 polytrauma rehab centers for traumatic, not necessarily 4, but those who have traumatic brain injury and have been admitted for inpatient rehab in 4 of the VA polytrauma rehab centers, and to essentially do the same data collection. And so this is a 4-year-old initiative supported by annual interagency agreements between NIDR and the VA. So they provide the funds, and the same data center that houses the TBI model systems database also houses the VA PRC database. In addition to essentially replicating the model systems database, the VA PRCs, collect additional information. So there are several additional measures that they have in their database. And the promise for this is that when enough subjects have been accrued to the VA PRC database, that there will be the opportunity for comparative research across these two databases.
One caveat to this, because I think it'd be very powerful to use this for planning clinical trials or interventional studies. The caveat is the obvious thing is people who come into clinical trials are different from people who participate in observational studies. They tend to be more highly educated. They tend to be, but that's okay just to keep that in mind. But I think it would really refine the precision of interventional studies by taking advantage, harnessing all these data.
We'd love to see it used that way, sure.
Thank you. Was there a question? Did you have a question? No? Okay.
I've lost interest.
Oh, can you say that in the mic, please? So we can get that. That was really good. All right. Okay. Let's go on. The next one has to do with how treatment can inform studies of other domains. And then
Should
we're
we
going to
go
go
back-
back to
oh,
number
really?
3. Yeah. Actually, maybe we should do that now. Yep. Yeah, I think we do. You're right, Mona. So let's go back to number 3, which is, number 2. What should the broad goals be of this kind of research? Mona, you want to start us out?
So we felt there were still a lot of very basic questions like who the treatment would work for, which aspects of the treatment were conferring the effects, and whether there were long-term effects. So we felt there was still a need for a lot of sort of more proof of concept studies before going on to a multi-center replication.
Okay, so which aspects, the long-term effects? Okay. Heather?
We really had this, I don't have a whole lot to add. I just have a long list of problems with the study that my group found. And
Okay.
We devolved into a conversation on Sesame Street, so.
Yeah, we did.
On that number.
That was
But it's
going to be one of
similar-
our comparison groups.
Similar thought process.
Yeah. Okay. How about Theo?
Same here. The only addition that we have was perhaps as part of proof of concept, a single subject design with the imaging prior to the treatment to optimize treatment based on the neural networks that are the ones
Okay.
that have the lesions.
With imaging that,
So pre and post imaging.
right. So pre and post, that the imaging that reflects these networks that supposedly APT is working on.
Right.
Okay. And we really did get at some of these issues when we talked about design and the comparator, and so reflects these networks by APT. Okay. Any other comments from anyone else about where this research should go or what the broad goals of this line of research should be?
Well, apropos your comments in the work group, that nobody in his right mind, or in some mind, offers pure APT anymore. It's always APT, what other things. I think where this research maybe should go is, does training of just the attention muscle, or training of just the memory muscle, or any of those things by itself make any sense? Or should we have a somewhat broader, a lot more difficult program of research, whether top-down is better in this area of cognitive remediation, bottom-up, or under what circumstances to get the maximum effect, you need both at the same time.
Okay, thank you. All right. Not to keep us too much longer, how could this treatment inform other studies, and what characteristics or conclusions are relevant to the broader picture? And these kind of go together. So 7 and 8, broader applications and different domains. So Theo, can you start us off?
Yeah, some of the comments that were made were that we needed to make use of observational studies more as kind of an initial phase of treatment.
So use observational studies more.
It also, there is a variety of measures that were used that tapped into different aspects of the outcomes, so that was something that future studies could use. And although this wasn't mentioned in the group, knowing the intervention, I think from the treatment, because the question is how can the treatment inform studies, is that this is one of the most well-packaged treatments available.
Right.
And the authors have done a great job putting it together, and it's not just, oh, send me a PDF file of your treatment or a Word document.
Right.
It's really well done, and the third iteration, actually, APT3 is available, and that's
right.
A computerized program. So what can we learn from that? Well, we can learn to package our treatments better, to write our manuals more thoroughly and more comprehensively, and use those for our clinical trials with all the benefits that come with that.
So we should all get to work.
Yeah.
And package our, okay. So it's a packaged program. It's fairly comprehensive, and this is the third iteration is out, right? Yeah. Heather.
Similarly, my group talked about the fidelity here, and it's a package, it's manualized, so that's a real strength and could be an example. However, apparently it has not been, this study in particular hasn't been replicated. I think
it has not.
You brought that up. We talked about liking the mixed methods, the quantitative and qualitative piece, and how that could be built upon a little more.
Okay. Mona.
So we, some of those also came up, but we also just want to mention that here the study was aimed more at an impairment, and that in some ways made it more straightforward than the previous study that was more sort of a broader disability.
Okay.
That's true. So.
And is that something that should be considered in other domains, or?
It's just kind of a general principle that it seemed.
Okay, so
that they had this, you know, it was, yeah, impairment versus, I guess, disability influences.
How about impairment-based treatment has a more narrowed focus, or?
More straightforward, whatever that means, because you can make the inferences more directly.
Okay. And
something that came out that just came out through the discussion with this, because we started talking about what you would want for outcomes, and then it was like, well, is there some kind of generic outcome that would be great? Because someone said there's hundreds of neuropsych outcomes, but you know, is there something that is better than the others? Is patient report, you know, better than something that's more objective? So I think that just is a broader issue that. It's important, but I don't think we need to think about that.
Yeah, actually, in our group, we talked quite a bit about self-efficacy and wondered if the self-efficacy piece was actually contributing to the education finding. So, you know, if there was a measure of self-efficacy, which there are some general ones, that might be an outcome that should be considered for the future.
I mean, it partly came up because I know that we at my agency have been investing heavily in some large validation studies of like neurological outcome measures, and and that's when David said, yeah, well, there's lots of others too, but I guess since we're making these huge financial investments, it just seems like we should think about using them or something.
Oh, that's great. I love that. Okay. All right. Oh, I'm sorry. Jim.
But just to expand on that, when we were discussing this, a light bulb that kind of went off for me. I don't know if it went off for anybody else, but it seemed like a study like this, where the target is a very focused impairment level problem, lends itself to an RCT a lot better than in the previous study, where the intervention's broadly based, the target is really fairly broadly based. It seems like that kind of intervention, where you're including everything but the kitchen sink, you really could think more about an implementation style sort of research program where you're just rolling it out and looking, in a broad way about how it does, while, in the meantime, you're kind of backtracking and looking at components, more specifically.
Okay. Oh, that's a nice way of thinking, almost like an outcomes-based research rather than an intervention-based research. So, John?
I was just wanting to remark on the virtue that a couple of you talked about of having this well-developed manual, but to me, actually, it seemed a little out of sync with what our general frame on the maturity of this study was. So here you have intervention level 3, well-written, distributed to people, able to govern a treatment that we have darn sparse data on the utility of. So for me, I'd develop a pretty lightweight manual that's good for me and my immediate colleagues to operate on in our single center study. I'd probably do a few iterations, try to figure out how it can be improved, and it's closer to when I want to start doing multi-center studies that I'm going to go to that kind of manual. I think what it ultimately reflects is that the developers of the technique believe in its clinical dissemination at a level of evidence that not everyone might agree with. So.
Just one point about outcomes. I think in terms of evidence, that it's really important to think about generalization. And not only do we want to look at, does this technique actually improve impairment level function, we want to look at, well, if it does, are we just improving it on a limited number of tests? How far does it generalize? Does it generalize to some impairment level activities that are a little further away from exactly what was taught here? And then does it start to generalize, as John was alluding to, does it start to generalize to some activities where we know that this attention would be involved, although there are other issues? Because if it doesn't generalize at all beyond a very limited extent, then ultimately we're not really very interested in it, except as an academic exercise and as a possible springboard for future efforts.
Any other comments? Okay, so there was quite a bit of overlap in the comments and quite a bit of discussion about where this should head. There have been additional studies. This was an older study, but there have been no replications of this and no even close, like what could be considered a springboard from this study. So that is a general issue in all of the CRT literature, is that we see very few studies that are very close to another study. It tends to be that people will have different patient populations, different selection criteria, different kinds of methodology. So that's been pretty unfortunate. Anyway, do you want to make a couple of remarks, or John, you're going to finish them? Okay.
Thank you, Mary. So I hope that these exercises today were productive. We didn't imagine that you were going to nail down the answer to each of those questions because, of course, those questions are intertwined. So if you have 2 or 3 purposes that the next study could do, then you're not going to have one outcome measure. You're going to have different ones for different purposes. So hopefully thinking through how those things would interrelate was worthwhile. We're going to pick this up again tomorrow with the least mature example. So the one where we will be closest to starting with a new idea, with a theory that has been hardly tested at all. That's going to raise some different issues. Then, importantly, we hope by the end of the half day tomorrow to get to some notions about where this could lead, especially within the military health system. That, as you heard, we're not here to issue IOM recommendations on where it should lead, but hopefully some of the principles that we've talked about, and especially with our military health colleagues here, you can think about what you think would be productive. Where should resources be directed? What are the opportunities given who you treat and what you treat them for? Are any of the things we've talked about specifically things you might want to move forward? Are they examples of the kinds of things you might want to move forward? And so hopefully we can get a little bit more grounded and concrete tomorrow about what the implications of these discussions could be. Any questions? Any housekeeping issues? Okay, so have a good evening. We'll see you tomorrow morning.